Okay, let's get started with this podcast for Chapter 10. This is a relatively short podcast. We will be covering 22 pages in the textbook. There will be 21 slides in this particular podcast. You would probably want to look over the case scenario at the beginning of this chapter. Team 11 has been assigned to do a videotaped case presentation involving this case. Anna, in that case, has Alzheimer's. She's in her 80s. Her daughter is thinking about putting her in a long-term care facility. But that's the most I'm going to say about this. Team 11 will cover it. You need to focus in and take a good look at Exhibit 10.1, which involves distribution pharmacies functions. Exhibit 10.2, which is selected pharmacist activities in these long-term care environment like nursing homes. And Exhibit 10.3, the drug regimen framework, which it lists out what pharmacists actually do in these long-term care facilities like nursing homes. Again, 21 slides we need to cover. There will be 6 IRATs. I will be hinting at the answers. There are 12 objectives that you see here. We'll be addressing each of those as we go through the podcast. First of all, what is a long-term care facility? It's defined as a set of health, personal care, and social services delivered over a sustained period of time to persons who have lost or never acquired some degree of functional capacity. So you'll not only see elderly folks here, you'll also see children, with muscular problems, palsy, and so on. Health, social, and residential services provided to chronically disabled persons with functional or cognitive impairments. In long-term care, help is given with activities of daily living called ADLs and instrumental activities of daily living called IADLs. Now, bear in mind, instrumental activities of daily living are things that involve more cognitive function. So things like grocery shopping, balancing your checkbook, that might be an example of an instrumental activities of daily living, where activities of daily living are more like physical, like walking. So usually when you see an elderly person getting up in age, they typically have trouble with IADLs first and later with ADLs. And you see that here in the next slide. You have assisted living facilities where there's care and support services available in tandem with independent living. So these folks that are getting older, they still have these ADLs that we talked about, but maybe they're having difficulty with the IDLs, like checkbook, grocery shopping, and so on. There are adult day services where people come in and allow family members, caregivers, like an older daughter to leave, get a little stress relief. There's home health care. This is things like Meals on Wheels. It may be people delivering unit dose medications to the home. Or infusion services, IV meds. There's hospital palliative care for terminally ill patients. If a doctor feels like their patient will probably die within 6 months, of course they don't know for sure, they'll write an order to hospice, especially if it's like a Medicare patient. Medicare covers hospice, so it's really essentially free for elderly folks once the doctor signs that order. The nursing home bed, however, is not free. So if you're at home, hospice is free. If you're in a nursing home, the hospice is free, but the nursing home bed itself is not free. Hospice is not a place, it's a service, so keep that distinction in mind. Now, on this particular slide, an IRAT will come from this slide. I want you to know that a patient could remain in his or her home for adult daycare and hospice. If you're talking about other forms of care, like skilled nursing home or a skilled nursing facility, they have to move out of the home. So when you're talking about a patient remaining in his or her home, they can get adult daycare and hospice while at home. Okay, types of services available, moving on. Skilled nursing facilities, patients needing medical care, nursing care, and therapy. Specialized institutional care, patients with cognitive decline. Long-term acute care, patients needing care that may not be available in skilled nursing facilities. Continuing care, retirement communities, psychiatric institutions, and also even in prisons, they have these long-term care facilities. Factors determining long-term care needs include level of disability, like those changes in instrumental activities of living and activities of daily living, availability of informal caregivers, financial circumstances, available of public programs, and personal circumstances. Again, this is different for different people in different places. So like in a state like New York, there's more services available than maybe in a poorer state like Mississippi. It also depends on the family. Maybe they have a child that can help them. Who needs long-term care services? Older adults, primary users. They are the primary users of LTC services. They may need help with instrumental activities of daily living or activities of daily living due to chronic disability, disease or disability. There are patients with chronic disease, those people with end-stage renal disease, dementia, Parkinson's, stroke, patients with rehabilitation needs, and terminally ill patients. So I've worked in nursing homes. I've walked in. I've seen physical therapists working with children in beds who have muscular paralysis and such. So again, it really there's all kinds of services available. Paying for long-term care, Medicaid, and private insurance. It depends on the state. It's based on income and assets. It's needs-based, and it's a type of long-term care covered, includes skilled nursing facility and home health care. Now, we'll talk about spending down. I really don't want to get into this right away, but Medicaid is not available to everybody. However, when they get older, and they start spending down all of their savings, they reach a certain point where they can start getting Medicaid. There's also private insurance. It provides financial assistance with the cost of long-term care, and plans vary greatly. So some private insurance involves paying for LTC and some doesn't. You have to be very careful when you're getting older to pick the one. Usually they're much more expensive. Long-term care insurance, type of private insurance, again, differs from one company to another, provides financial assistance in the event a person needs long-term care. Benefits vary. Premiums increase as age purchase increases. Out-of-pocket used when ineligible for Medicare and Medicaid or lacks private insurance. Now, a couple of things I would point out on this slide. Long-term care insurance is very expensive. I know I went over this with my financial advisor, and he asked me about my family history, and I said, well, usually when the older men in my family die, they die pretty quick. They don't seem to ever need long-term care insurance. So the financial advisor, kind of discouraged it because it's so expensive. If need be, we can take money out of our 401k or something, our IRA, and use it for that. Now, the Medicare versus Medicaid, please be advised that Medicare will cover a nursing home, but only for like a 30-day or 100-day, depending on the circumstances, limit. So after that, it won't pay anymore, and you switch over to Medicaid if you don't have much money in your savings. And again, that state sets those parameters. There's other options. There's reverse mortgages where a person or a married couple has paid off their house. They start getting payments in reverse. So instead of paying a mortgage, you get money back, and you can use that to pay for long-term care. There's trusts where you're getting money from somebody like a father or a mother who died, who was rich and left you money. Long-term care annuities, you can get these through insurance companies like life insurance companies and so on. The future of long-term care, there's the Patient Protection and Affordable Care Act, also known as Obamacare. It seeks to improve health care and lower costs. It coordinates care through a patient-centered medical home and community services. We've already talked about this. There's aging in place, which is staying in the same home and community as care needs change. There are continuing care retirement communities that contain independent assisted living and skilled nursing care on a single campus, can move among the different levels of care without relocating. So like I lived in a planned community down in the Virginia area, and it had apartments for young adults. It had single-family homes. It had all these kinds of independent living, assisted living, and skilled nursing home, all in the same planned community, and these are becoming more common. The program of all-inclusive care for the elderly. It integrates all aspects of care covered by Medicare and Medicaid, and patients must meet criteria to qualify for this. Pharmacist opportunities in long-term care, distribution, provide specialized packaging such as unit dose, discuss dosage form alternatives with healthcare team, provide delivery services, provide on-site counseling services, aid in developing policies and procedures, and manage drug-related forms and reports. Now, there's a IRAT that comes from this particular slide, and I want you to know that pharmacy services and long-term care can be divided into two categories. The first being distribution, and the second being consulting. So you see distribution on this slide. The other category is on this slide, consulting. So when you're talking about like long-term care nursing homes, you could be a pharmacist who does the distribution, or you can be the pharmacist who does the consulting. It's very rare if you have a pharmacist who does both the distribution and consulting. They're usually separate. So you can do the consulting in a nursing home, but somebody else does the distribution. Okay? Consulting is performing medication regime reviews, MRRs, drug utilization evaluation, DUE, and drug utilization review, DUR. These are all different. We'll talk about this much more as we progress through the course. You monitor patient outcomes and aid in pharmacokinetic dosing. Oftentimes when you get older, you have changes in your renal, your kidney function, or your hepatic function, your liver function, and you have to adjust the dosing. You identify and resolve drug interactions. You select cost-effective medications. You educate healthcare providers. You perform medication reconciliation, and you do MTM services. There's an IRAT that comes from this particular slide. You need to know that the benefits of pharmacist involvement in the care of residents in long-term care facilities include three things. Reductions in the total number of prescription medications taken. Secondly, the reductions in inappropriate drug utilization as a result of multiple prescribers. And third, reductions in total medication costs by switching brand medications to generics or other therapeutic alternatives. So the pharmacist's involvement in the care of residents in long-term care facilities is many. MRR, DUE, and DUR. I spoke about that earlier on the first bullet under consulting. Here is a more of an explanation of those three types of review. Medication regime review, MRR, is the evaluation of a patient's medication regime with the goal of promoting positive outcomes and minimizing adverse consequences. That's MRR. DUE, or drug utilization evaluation, is criteria-based, ongoing, planned, and systematic review of medications, their use, and contribution to outcomes. It's prospective. So it's like you see a patient, you start seeing a patient, and you do this into the future. Drug utilization review, DUR, is retrospective as opposed to DUE. So DUR is the review of past patterns of medication misuse, monitoring current medication therapy, and offer patient counseling. Retrospective. This is all retrospective. So keep this in mind, that MRR is the evaluation of the patient's medication regime within the goal of promoting positive outcomes. DUE is prospective and DUR is retrospective. Now, a question, IRAT question, will focus in on this particular slide. You need to know that medication regime review, MRR, drug utilization, DUE, and drug use review, DUR, are clusters that describe the services that are provided by a consultant pharmacist practicing in long-term care, in a long-term care setting. So all three of these are provided by a consultant pharmacist within like a nursing home. Medication reconciliation is a process by which medications are accurately and completely accounted for throughout the care process. This is a terminology you'll hear a lot of, especially when you start your second year with your PT courses. The goal is to avoid adverse drug events due to inadequate communication between and among healthcare providers, especially during the transfer process. So medication reconciliation will occur like if you're in a hospital and somebody is admitted to the hospital. Oftentimes the doctor will prescribe things for the patient while they're in the hospital, but the pharmacist will come up behind and say, hey, well, wait a minute, this patient was also taking this for their diabetes or this for their hypertension. Maybe they should be taking this as well. That's reconciling, making a change in the medication list. Pharmacist opportunities in long-term care continued. Participation in quality assurance activities, like if errors occur, what they can do to prevent them in the future. Pharmacy and therapeutics committee involvement, like deciding what to have or what not to have on their formulary and available to patients in the long-term care facility. Medication therapy management, unique practice settings, palliative care, which is hospice. It's keeping them comfortable until they die. Prison inmate care, substance abuse patients, and patient-centered medical home. Patient-centered medical homes, springboarding off that last slide, they're comprehensive care of the whole patient from preventative care to chronic care. They address patient values and preferences. It's team-based care led by the clinician, coordinated to avoid transition of care issues. Pharmacists can perform medication-related services to improve quality and safety. Now on this very last slide, preparing to practice in long-term care, these are suggestions to students who may be interested in this. There are rotations like IPPs, APPs, there's residencies, there's fellowships. The Board of Pharmaceutical Specialties has a geriatric pharmacist certification, and there's different training programs. Be advised that we give an elective. Dr. Butterfoss, Dr. Jadek, and I provide an elective to students in their third year involving geriatric care, consultant pharmacy. So you might want to think about taking that 2-credit course. There's a NIRAT that comes from this particular slide. I need you to know that there are different types of resources available to consultant pharmacists who wish to further develop their patient cares, and it involves basically 3 things. National professional organizations devoted to senior care pharmacy, such as the American Society of Consultant Pharmacists. It's abbreviated ASCP. There's traineeships in geriatric topics of interest, such as Alzheimer's disease or dementia. And also there's examination for designation as a certified geriatric pharmacist that I mentioned earlier. And that's the end of this podcast.